Everyone is looking for a pill that fixes metabolism. Ozempic, Wegovy, GLP-1 injections, they are everywhere. But here is the uncomfortable question no one is asking. What if one of the most powerful metabolic drugs was never a drug at all, but walking using your own legs? Today, I'll compare walking versus medications, including Ozempic, using real physiology, not hype. Peace be upon you, and welcome back to Ment Human. I'm Dr. Haitham Faraj, a certified cardiologist, nutritionist, and a personal trainer. Let me clarify something very carefully, because this is where people understandably push back. When I said in my previous video that walking works like medication, I received a comment saying that this statement was misleading. So let me be very clear. I'm not claiming magic, placebo, or that walking has some mystical property on its own. And I actually agree with part of the criticism you're seeing in the comments. Because walking works through real, well-described physiological mechanisms, not slogans. What I meant and what I'll explain clearly today is that walking produces measurable, drug-comparable biological effects when we judge it by the same standards we use in medicine. Yes, the benefits of walking come from muscle contraction, energy expenditure, and cellular signaling. Yes, cycling, resistance training, and other forms of movement can activate similar pathways, including GLUT4 translocation and vascular effects, when the dose is right. That part is correct. But here is the medical clarification that matters. In medicine, we don't judge an intervention by whether it's special or unique. We judge it the same way we judge a drug. How fast does it work? Which biological pathway does it activate? What is the magnitude of the effect? And what are the side effects and risks? When you apply the same clinical framework, walking absolutely qualifies, because walking produces immediate insulin-independent glucose uptake in skeletal muscle, activates well-defined molecular pathways, GLUT4, AMPK, nitric oxide signaling. It has reproducible effects on blood sugar, blood pressure, and inflammation, and does so without pharmacological side effects. So when I say walking works like medication, I'm not saying it's biologically magical. I'm saying it produces drug-comparable physiological effects, often faster than people realize, and with a risk profile no medication can match. And here's the final point the comments often underestimate. Walking is not just effective, it is low stress, low cortisol, and repeatable multiple times per day, especially after meals, when many other forms of exercise are neither practical nor ideal for metabolically unhealthy individuals. So yes, the mechanism is muscle movement, but clinically, walking earns the comparison to medication. Because in real patients, real physiology and real outcomes, it behaves like one. Walking activates insulin-independent GLUT4 translocation to the muscle cell membrane, increasing glucose uptake, lowers postprandial glucose within minutes, reduces glucose spikes without increasing insulin. This overlaps with metformin via AMPK activation, acarbose by flattening glucose peaks. Studies show that 10 to 20 minutes of walking after meals can reduce post-meal glucose excursions by 20 to 30%, especially in insulin-resistant individuals. The key difference, drugs work once per dose, but walking can be repeated after every meal. Now let's be honest and fair, because this topic is emotional and it deserves balance. GLP-1 agonists like Ozempic did not appear out of nowhere, and they are not useless. They exist because morbid obesity is a serious disease. And for some patients, medications are necessary tools. What Ozempic does well, it actually reduces appetite and calorie intake, slows down gastric emptying or your stomach emptying, increase glucose-dependent insulin secretion, and can lead to significant weight loss, especially in morbid obesity. In selected patients, this can be clinically helpful. So let's be clear. These are tools, not evil drugs. But this is where the public conversation often stops and where the problem begins. What rarely gets discussed is what GLP-1 drugs do not correct. Ozempic does not build or preserve muscle mass. It don't increase mitochondrial density. It doesn't improve skeletal muscle insulin sensitivity directly. It don't reduce cortisol or stress signaling, and it doesn't improve movement capacity or cardiorespiratory fitness. It also doesn't restore metabolic flexibility. And this matters because muscle is the primary organ of glucose disposal. Now here is the critical part related to the comment you saw. Once the drug is stopped, appetite often rebounds, weight regain is common, and the underlying metabolic dysfunction is still there. That's why many people sense correctly that the current GLP-1 craze, when used as a standalone solution, may not end well. Not because the drug is bad, but because a pill alone cannot replace a broken metabolic system. Now compare that with walking. Walking actually increases insulin-independent glucose uptake in muscle. It preserves and protects lean muscle mass. It lowers basal insulin levels over time, preferentially reduces visceral fat, not just scale weight. It also improves mitochondrial function and density. It enhances endothelial nitric oxide signaling and lowers blood pressure through autonomic balance. But most importantly, walking retrains metabolism instead of bypassing it. It improves the system that regulates energy, glucose, and insulin rather than outsourcing a control to a drug. This is why so many people intuitively feel uneasy about the everyone wants a pill mentality. GLP-1 drugs can be helpful in severe cases, supportive in selected patients, but they were never meant to replace movement, muscle function, and metabolic signaling. Walking does not compete with Ozempic as a weight loss shortcut. It competes with it as a metabolic therapy. And that distinction changes everything. And I'll say this honestly, but with care. I'm not against these medications. I'm against making them an excuse to stay sedentary. If you can walk, walk. God designed the human body to move. And medication was meant to assist that design, not override it. The current GLP-1 craze isn't really about Ozempic. It reflects a deeper problem in modern healthcare. Unfortunately, people want results without rebuilding the system that broke. That's understandable. We are busy, tired, and overwhelmed. But biologically, it doesn't work that way. No drug can replace muscle mass, replace daily movement, or replace the metabolic signaling created by muscle contraction. Because those signals don't come from chemistry alone, they come from use. This is where the pill mentality becomes dangerous, when medication is used as a substitute for lifestyle. The symptoms improve, the root cause remains. Dependency increases, and long-term resilience declines. Medication was never designed to replace biology. Its role is to support, stabilize, or buying you some time, while the underlying system is repaired. Used correctly, medication assists lifestyle. Used alone, it just postpones the problem. And this is the distinction that matters most. You don't fix a broken metabolism by silencing appetite alone. You fix it by restoring muscle function, movement signaling, hormonal balance, and metabolic flexibility. Drugs can help, but they cannot work for you. Now let's talk about blood pressure, because this is where walking is often underestimated. Regular, consistent walking improves arterial compliance by reducing vascular stiffness, enhances endothelial nitric oxide production, allowing blood vessels to dilate more effectively, lowers sympathetic nervous system tone, which reduces resting heart rate and vascular resistance, and is associated with lower risk of atrial fibrillation and premature atrial or ventricular beats. These are the same physiological targets we aim for with first-line antihypertensive drugs. When walking is done consistently, the average blood pressure reduction achieved with walking is comparable to low-dose ACE inhibitors or ARBs, particularly in patients with early hypertension or metabolic dysfunction, and comparable to low-dose beta blockers in reducing resting heart rate through improved autonomic balance. And here is the key distinction. Walking achieves this without electrolyte disturbances, without dizziness or orthostatic hypotension, without renal stress or drug interactions. It doesn't override the system, it normalizes it. That's why in early metabolic disease, walking is not just an adjunct. It functions as a foundational antihypertensive therapy, and when medication is eventually needed, walking amplifies the effect rather than competing with it. Let's now talk about inflammation and insulin sensitivity, because this is where many chronic diseases are actually driven. Regular walking has been shown to reduce key inflammatory markers including C-reactive protein, interleukin-6, tumor necrosis factor alpha. These are not cosmetic markers. They are active drivers of insulin resistance, endothelial dysfunction, and atherosclerosis. What's interesting is that this anti-inflammatory profile overlaps with what we see from potent insulin sensitizing drugs, particularly thiazolidinediones, such as Pioglitazone. Those drugs work by activating PPAR gamma pathways to improve insulin sensitivity, but they come at a cost. Pharmacological insulin sensitizers are associated with weight gain, fluid retention and edema, and increased risk of heart failure in susceptible patients. Walking, on the other hand, improves insulin sensitivity through muscle contraction and mitochondrial signaling, reduces inflammatory cytokines by lowering visceral fat and oxidative stress, enhances glucose disposal without forcing fat storage or fluid retention. In other words, walking improves insulin sensitivity by fixing the biology, not by overriding it. So while drugs like Pioglitazone attempt to pharmacologically compensate for metabolic dysfunction, walking actively reverses the environment that caused it. No weight gain, no edema, no heart failure signal. Just a quieter immune system and a more insulin responsive body. Before we continue, let me pause here for a moment because this is important. Everything we've talked about so far, walking, insulin resistance, inflammation, and GLP-1 drugs, and what we are about to discuss next, cholesterol and statins, all connects to a much bigger misunderstanding in modern cardiology. That's exactly why I wrote my book, Is LDL Really Our Enemy? In the book, I explain why LDL numbers alone don't tell the full story, the difference between LDL quantity and LDL quality, how insulin resistance, inflammation, and lifestyle drive heart disease, and why focusing only on pills without fixing metabolism keeps people stuck. This book is not anti-statin and it's not anti-medicine. It's pro-understanding. If you want the full framework, not sound bites, not fear-based advice, but a clear evidence-based explanation written for both doctors and patients, you'll find the book linked here. Take your time with it. It's meant to change how you think, not just what you take. Now let's continue because this connects directly to statins and walking. Now let's talk about lipid-lowering therapy, particularly statins, because this is where a lot of confusion exists. Now, statins are effective medications. They work primarily by inhibiting HMG-CoA reductase enzyme, reducing hepatic cholesterol synthesis, eventually lowering LDL cholesterol levels. In selected high-risk patients, such as patients with acute myocardial infarctions, statins can be life-saving. That's an important point, and it should never be ignored. But cholesterol numbers are not the full story. Statins also exert important anti-inflammatory and plaque-stabilizing effects within the arterial wall, which explains part of their cardiovascular benefit, even beyond cholesterol numbers. However, it's essential to understand the scope of these effects. Statins primarily act on cholesterol production and arterial and plaque level inflammation. They do not directly restore metabolic health, muscle function, or insulin sensitivity. And that distinction is critical when deciding who needs statins, when they are appropriate, and why they are being prescribed in the first place. Now, what statins do not fix? Statins do not improve insulin sensitivity, they do not reduce visceral fat, they don't improve mitochondrial function, they don't build or preserve muscle mass. Also, they are not able to improve cardiorespiratory fitness. They don't correct lifestyle-driven metabolic inflammation. And in some individuals, statins may worsen insulin resistance, increase the risk of new-onset diabetes, and cause muscle symptoms, fatigue, or exercise intolerance. Again, this is not because statins are bad drugs. It's because they act on one biochemical pathway, while metabolic disease is a multi-system problem involving muscle, mitochondria, hormones, inflammation, and behavior. And this is not theoretical. In a previous case I presented, I discussed a patient who was fully compliant with statin therapy under family medicine care. He had an extremely low LDL cholesterol, but was sedentary, with poorly controlled diabetes, despite good cholesterol numbers. That patient presented with a fatal acute myocardial infarction. That case illustrates an uncomfortable truth. Statins alone do not make you metabolically protected. They reduce risk, but they don't replace movement, muscle function, or metabolic control. Understanding this difference is what allows statins to be used wisely as part of a broader strategy, rather than reflexively as a standalone solution. Now, what walking does that statins cannot. Walking affects lipid risk upstream, not just downstream. Regular walking improves LDL particle quality, larger, dense, less atherogenic particles, lowers triglycerides, and it raises HDL functionality. It reduces systemic inflammation, improves endothelial function, reduces visceral fat, a major driver of dyslipidemia. However, walking doesn't lower cholesterol by blocking synthesis. It improves lipid profiles by fixing the metabolic environment that creates dyslipidemia. That's a fundamental difference. Walking can reduce lipid risk even when LDL numbers don't dramatically change. It improves plaque stability, inflammation, and vascular health. And when statins are needed, walking amplifies their benefit and reduces reliance on higher doses. So this is not walking versus statins as enemies. It's this. Statins manage risk. Walking changes risk. One treats the marker, the other treats the biology behind the marker. Closing line for this section, statins can lower cholesterol, walking improves the person carrying the cholesterol. And that difference matters more than most people realize. Let me be very clear, because nuance matters. I am not anti-medication. GLP-1 drugs do have a role in selected patients. Statins and other therapies save lives in the right context. But walking is not inferior medicine. It is under-prescribed medicine. Walking addresses muscle function, insulin sensitivity, inflammation, vascular health, hormonal balance, all at once. And if walking were packaged as a pill, doctors would prescribe it without hesitation. Insurance companies would cover it. And its side effects, lower blood sugar, better blood pressure, improved mood, and better sleep would be considered benefits, not risks. So the question is not, does walking work? The real question is, why aren't we prescribing it with the seriousness it deserves? Because the most powerful metabolic therapy we have doesn't come in a syringe or a tablet. It comes with two legs. If this video helped you rethink exercise, medication, or metabolic health, please like the video. It really helps this message reach more people. I'd also love to hear your thoughts. Do you believe walking should be prescribed like medications? Drop your opinion or question in the comments. I read them all whenever I have time. And if you haven't already, make sure to subscribe to the channel, because we're not here for trends, we're here for understanding. Now this video connects directly to another important discussion I made earlier about exercising more and whether it can actually increase heart disease risk when done incorrectly. I strongly recommend watching that video next. It adds an important layer to what we discussed today and helps put exercise into the right context. You'll find it linked here. Until next time, keep moving, keep questioning, and take care of your heart. That's it for today. Peace be upon you. Assalamu alaikum. Increased risk of heart failure.